It's a pleasure to come back and share some more insight with my experience with the Richie Brace over the past 20 years. And as we alluded on a previous webinar, we covered adult acquired flat foot, but there were a lot of other pathologies that I wanted to share with the folks that were attending. And it was a pleasure to learn that there was great interest in it. So we're going to go ahead and delve into some other topics. Before we do, just to look in perspective of my career as a podiatrist, when I went to podiatry school and graduated in 1980, I had a wonderful curriculum of biomechanics that allowed me knowledge of the motion and muscular actions of all of the muscles and the joints of the lower extremity. And I took a lot of courses in pathologies affecting the lower extremity. But when it came to treating these pathologies, the musculoskeletal conditions, I really had this in my toolbox, the custom foot orthotic. That was it. And happily, over my career, I've seen podiatrists become expanded in their scope of practice, such that now when you have a patient like this come in, and I'll tell you a little bit more about him later, who's got obviously a flaccid drop foot deformity. This, of course, would not respond to a custom foot orthotic, but it does respond to a specialized version of the Richie brace known as the dynamic assist. And now having these tools available opens up a whole new dimension of podiatric practice that can actually provide some of the greatest rewarding experiences for you as a practitioner that you could ever have. So this will kind of whet your appetite for what we're going to talk about. I wrote an article about 10 years ago just summarizing the biomechanics of ankle foot orthoses, which are much different than the biomechanics of foot orthoses. And I'm just going to summarize some of the findings of that for you. You know, foot orthoses really function by redirecting ground reaction forces and ultimately change joint moments more proximally located to the foot orthotic itself. Foot orthoses primarily affect the subtalar joint and indirectly affect the mid-tarsal joint. And one thing we learned really 20 years ago was that foot orthoses profoundly affect joint moments, but they don't really affect alignment in a noticeable way. And so we're redirecting ground reaction forces through the rear foot, the ankle, the knee, and the hip. And we're seeing changes, very positive clinical changes, but we don't see real positive alignment changes. And these are just a few studies. Most of you are aware of these where surprisingly, foot orthoses only improve alignment during walking or running gait on the order of 1 to 2 degrees. And they really rely on their effect of altering ground reaction forces with the shape of the foot plate itself and the contouring of the foot plate to certain key areas of the plantar surface of the foot. Well, we can still embody that strategy with ankle foot orthoses. We can build a medial skive into a Richie brace and still get some of the positive effects we see with foot orthoses. But by extending the brace above the ankle joint, we now can apply force couples in multiple locations to profoundly affect alignment. And so now we can actually realign the entire foot and ankle, not on the order of 1 or 2 degrees, but in the order of 30 to 40 degrees. And so in comparison, foot orthoses really act during the stance phase of gait only. And what's profound about AFOs is that we can now bring into an effect during swing phase. We can directly control the ankle, we can directly control the tibia, and we do so by applying forces above and below the ankle and rear foot complex. The way AFOs and the Richie brace work is restricting rotational motion at a joint. We can also restrict what is called translational motion, which is a pathologic motion. We can also offload a joint, which is really called axial offloading. And then using the foot orthotic concept, we can still redirect ground reaction forces. So when we want to control rotational motion of joints, we really have to have 3 points of fixation in order to bring a joint into a preferred position. And so when we use a solid shell ankle foot orthoses, which are still very popular around the world, they don't really have an ability to control what we call translational motion, and they primarily control sagittal plane motion. What we've learned is that these posterior shell type AFOs have little ability to control frontal plane and transverse plane deformities, such as the adult acquired flat foot. The translational motion occurs in adult acquired flat foot and chronic ankle instability when ligaments get ruptured. And when ligaments get ruptured, the joints become loose and wobbly. But in order to stabilize that anatomic part, we have to have a fairly rigid brace that's closely affixed to the skin of the lower extremity. So this is a complex rotational deformity that requires fixing a brace to the tibia and the foot and tightly cinching it to the anatomy. And it's that principle that we use with the Richie brace, and as we talked about the adult acquired flat foot in the previous webinar. And using this principle of tight affixing of the brace members to the skin and to the anatomy, we can control rotation. We can control transverse plane rotation of the tibia, and we can control frontal plane motion of the subtalar and ankle joints. This is the same concept that we see in these very high-tech knee braces that are worn by collegiate and professional athletes. These braces don't just simply control the sagittal plane. They're tightly affixed to the femur and to the tibia to control transverse and frontal plane motion. In order to be tolerated by the patient, you have to have straps and pads that bring the brace into the anatomy and fix it tightly without irritating the skin. So we follow this same principle with the Richie brace. We use a series of straps and pads, securing the brace to the lower part of the leg and to the plantar surface of the foot. The ability to tighten that strap and cinch the limb uprights to the tibia and fibula is critical to control transverse plane motion and critical for our control of drop foot, as you're about to see. So the Richie brace has multiple benefits over the traditional solid shell AFO. And I'm going to go over this in more detail as we talk about the pathologies. This is an example of a knockoff version of a Richie brace. We see these in the United States fairly frequently, where orthotists instinctively think that they need to secure the entire limb upright with a posterior bar of rigid plastic, really making the entire lower limb uprights connected in one solid unit. The problem here is you can't cinch it to the leg. Once this bar is placed across, you cannot tighten it any further. And this patient came in my office, and as you can see, she has significant internal and external rotation inside of the brace of her tibia. By securing the Richie brace and having the uprights independent, we can cinch it tighter to the medial and lateral aspect of the leg. And as we tighten it, this same patient, now in a true Richie brace, as she tries to internally and externally rotate, there's virtually no motion. Indeed, a study done by Chris McLean at the University of Massachusetts showed that the primary function of the Richie brace is to control transverse plane rotation of the tibia. We introduced the Richie brace almost 25 years ago, and it has evolved with multiple revisions and cast correction techniques. It's distributed by Firefly Orthoses in the UK and by 20 Foot Orthotic Labs here in the United States. It's also distributed in Canada by Paris Orthotics and Queensland Orthotic Lab in Australia. We've provided over 100,000 Richie braces to date to patients all over the world, and we've learned a lot. And we now know that we achieve a positive patient outcome about 95% of the time, with very few braces returned for modification. As I showed you in the previous webinar, the effects of this brace on adult acquired flat foot are profound. But I want to move beyond that now and talk about applying the brace, as we're going to start with drop foot conditions. We're going to go through Charcot-Marie tooth, post-stroke, and common peroneal nerve palsy. And then we're going to talk about decreasing load on other soft tissue structures besides the posterior tibial tendon, we're going to discuss the peroneal tendons and the tibialis anterior. So basically, what we're going to do is start with Dropfoot here. And basically what we're trying to do with a Richie brace is to restore motion. We're not really trying to limit motion as much as we are trying to preserve and restore motion, in this case, dorsiflexion motion that's been lost either by muscle or nerve injury. The type of patients who present to the podiatric practice with Dropfoot may have suffered a stroke or cerebral vascular accident, CVA. They may have Charcot-Marie tooth disease, they may have multiple sclerosis, or they may have suffered a nerve injury. We sometimes will see the unfortunate patient who's had a brain injury. All of these conditions can result in lower extremity weakness, spasticity, causing a drop foot during gait. There are two Richie braces indicated to control drop foot. The first brace is what we call the restricted hinge Richie brace. It will hold the ankle at 90 degrees during swing phase and prevent foot drop. But the other positive effect is it does allow 5 degrees of dorsiflexion during the stance phase. It is not an entirely rigid brace. It restricts dorsiflexion, but does not totally limit it. Another brace, which I'm going to show you, is called the dynamic assist brace. This is a fully articulated brace that allows free dorsiflexion, and in addition, it has these tamarack springs applied to the ankle joints. And these springs allow a dynamic recoil of the foot plate, providing approximately 15 degrees of dorsiflexion of the foot plate when the brace is lifted off the ground during swing phase. And so it's with this dynamic assist brace that we'll see this profound motion or correction of a drop foot positioned at 30 degrees of plantar flexion and now 15 degrees of ankle joint dorsiflexion during swing phase. Because the brace has a custom foot plate, we can do frontal plane corrections of the foot in case of need to control excessive pronation or supination compensation. So picking the correct brace can sometimes be a challenging situation, but I'm going to go through and just give you some simple pearls here and try to simplify the whole process. Obviously, when we evaluate any patient for an AFO, we have to watch them walk, and we have to do detailed gait analysis, joint range of motion, and muscle testing. And therefore, we look for stability of the knee, and we follow a simple rule. If the knee is stable, we can use an articulated AFO. If the knee is unstable, we have to use a restricted AFO to keep the tibia from moving and try to create stability proximally at the knee joint. So this is a real concern about looking at the knee. We sometimes just focus on the foot as podiatrists watching patients walk. But what we really need to do is look up higher and look at that knee. And it will be, when it's unstable, it'll either be flexed excessively or it'll go into recurvatum. And if the knee is excessively flexed or in extreme recurvatum, we can't use an articulated dynamic assist Richie brace. We have to go to a more stable or stiff brace to control the tibia. So when we see a child walking with a crouched gait, such as a child with muscular dystrophy, and the knee is excessively flexed, we need a solid AFO to straighten that knee. Most Richie braces will not address that situation. This is a patient who has another form of unstable knee. It's a polio patient going into severe recurvatum. Again, the desirable brace here would be a more solid brace to push the tibia forward and push the tibia out of recurvatum. So these patients with significant instability of the knee require a more stable or solid AFO to straighten. In the case of use, seeing a patient with an unstable knee, for the most part, the two Richie braces I just showed you would not be indicated to straighten the knee. It's really requiring a more solid AFO, and we're not going to be discussing how to use that type of brace in today's presentation because they're just, it's the next step above the standard Richie brace line of products. But the restricted hinge can give some of the benefits of a solid AFO, but still have some motion during the stance phase of gait. When we take the restricted hinge and add the arch suspender, now we've got a really powerful way to control frontal plane and sagittal plane instability. The one thing about the dynamic assist brace and all Richie braces is it must be cinched tight to the leg. And in particular, the dynamic assist brace, and we've just now posted these fitting instructions on our website, we recommend having the patients apply the brace with the foot dorsiflexed or with the tibia flexed forward anteriorly. And this really loads the brace and loads those hinges, and we cinch that strap tight. And now when we stand upright, these hinges are fully loaded and the limb uprights are perfectly aligned to the leg. If we let these limb uprights slip forward, we're going to lose some of the dynamic recoil of the dynamic assist brace. We can add more posterior stability to the brace. We don't like doing it with plastic, as I showed you in the previous slides, but upon request of the practitioner, we can add this carbon graphite ring posteriorly to provide some posterior stability. In my experience, that's rarely needed. So this is the restricted hinge Richie brace that has very little sagittal plane motion. Keep in mind, when we brace any patient with drop foot or any deformity, a brace can only move a joint and correct a joint if there's range of motion available at the joint. So we have to measure range of motion to make sure that range of motion is available. If there isn't 10, 15, or 5 degrees of dorsiflexion available, then the brace isn't going to move it any further than what the joint range of motion has. We can't remove Aquinas, a fixed rigid Aquinas, with any AFO brace. This is the dynamic assist brace. It requires a stable knee. The ankle joint has to be able to come to 90 degrees. It has to have available dorsiflexion to reach neutral. And in most cases, the patient should not have a lot of spasticity in the calf. While that may sound quite limited in the criteria, this brace is perfectly suited to a large number of patients with passive hemiplegia, particularly patients who have had a stroke. The dynamic assist brace is very popular here in the United States, treating thousands and thousands of stroke patients and patients with Charcot-Marie tooth disease. So if there's available range of motion to 90 degrees and no spasticity, we prefer the dynamic assist brace. If there is some spasticity and some contracture of the posterior calf muscle, we recommend the restricted hinge brace or even a solid AFO. So unstable knees require a solid AFO. If there's a fixed Aquinas, the brace will not move that ankle out of Aquinas, but it can provide frontal plane control over the ankle, even though the patient is still a toe walker. Spasticity is somewhat resisted by the restricted hinge brace or a solid AFO. The dynamic assist, of course, is preferred for most drop foot conditions, but it will fail if there's spasticity or fixed Aquinas. So I'm going to go ahead and show you a couple case presentations. This is, first of all, a patient who had polio. We don't see this too often. If we do see it, it's an elderly patient because thankfully the polio vaccine pretty much eliminated polio around the world. But I'm showing you this because he has a fixed Aquinas. I'm maximally dorsiflexing his ankle and I'm only getting him to about -10 degrees. So what I have to do in this case is adjust the Richie brace to Aquinas. I told the lab to set the foot plate into 10 degrees of plantar flexion to match the exact Aquinas the patient has. In order to allow him to heel strike, then we have to put a heel lift inside the shoe or outside the shoe. In polio patients, usually the affected leg is a little shorter than the other leg, but if it isn't, you have to add bilateral heel lifts. I have a better video I'm going to show you of this patient walking that isn't sideways. I'll show you that in a minute. Okay, so we're going to get to, here's that guy walking now. And although he has Recker bottom, this brace does a pretty good job of controlling his drop foot. You can see for now, he's heel striking. And he far prefers this brace than he does his solid shell AFO. Now, my criticism in this video is he doesn't have the back strap tight enough, and he's letting those limb uprights go too far forward on his leg, and he's losing some of the elastic recoil that he would normally get out of the brace. Okay, now I'm going to show you a couple stroke patients. This is a very mild stroke, but if you look closely, this patient is walking and forefoot striking on her left foot and heel striking on her right. She's got a mild left side hemiplegia. She drags her left foot. She trips and falls easily, but it's not a real obvious drop foot condition with a high steppage gait. So this patient is a perfect candidate for the Richie Dynamic Assist because she has full range of motion of her ankle, no spasticity, no equinus, and now you see that she heel strikes. The goal of treatment is to restore heel strike and to prevent toe drag during the swing phase of gait. And the nice thing is she's able to wear this brace with just low top lace-up tennis shoes. This is an interesting case of a younger patient who has lupus. And I didn't know this until I met this patient, but lupus has a subgroup of patients who have a hypercoagulability, and they are at risk for stroke. She didn't even know she had lupus. She went to bed at night and woke up in the morning with a full left side hemiplegia. She had a stroke while she was sleeping. She's 26 years old. Watch her left foot and notice her left arm. She has a left side hemiplegia. Again, not severe, but she's forefoot striking on the left. She's not heel striking. She trips and falls. Her doctor prescribed a solid AFO, which she hates to wear. She's 26 years old, and she's a mom. That's her young daughter there. So I elected to treat her with the Dynamic Assist brace because she had no equinus, no spasticity. And so now she can wear her lace-up tennis shoes. She has a low profile brace and she's heel striking. She's much more comfortable in this brace than she would be with a solid AFO. This is an interesting patient who had a common peroneal nerve injury causing a much more noticeable drop foot, but it's a flaccid drop foot. And his orthotist made him a solid AFO, which the patient did not like because he couldn't play tennis anymore. He came to me because he had read about the Richie brace and he wanted a brace that he could be athletic in. Specifically, he wanted to play tennis. I wanted to provide a Dynamic Assist brace, but I had to check and make sure. He has a flaccid drop foot, but I can dorsiflex him just past 90 degrees. He has no spasticity, no equinus. He's a perfect candidate for the Dynamic Assist brace. Look at what this brace does for a relatively healthy patient, restoring a totally normal gait, no evidence of drop foot, normal motion of all the proximal joints. And most important for him, he now can play tennis again. He plays tennis in this brace with no difficulty from his drop foot. He has full mobility because it's an articulated brace. Okay, so I'm going to move on here and show this is another common peroneal nerve injury that was a result of this patient dislocating his knee. And I'm going to show you an athletic patient who had the same injury. Severe anterior cruciate ligament knee injuries that are seen in football, soccer, will often have some degree of common peroneal nerve palsy because of the traction placed on the nerve. This poor fellow was left with a weak knee after surgery, but most importantly, a residual drop foot from the common peroneal nerve injury. You'll also see he has significant varus instability of his hind foot, coupled with the sagittal plane instability of the drop foot. So he was a good candidate for the Dynamic Assist, and just like our previous patient, we see almost a normal gait pattern restored with the Richie Dynamic Assist brace, as well as moderate correction of his inversion supination deformity. I could get better correction of the frontal plane deformity if I used a restricted hinge brace, but in this case, I wanted to restore motion to the ankle joint. Finally, this is a more profound case of a patient with a global lower extremity weakness after a stroke, where she has to circumduct her hip because she's lost all anterior hip flexion and all anterior lower leg musculature. So if we watch her walk without any muscular activity at all in her hip, she has to swing her hip into abduction as she's walking. There's the only way she can swing it forward. An AFO isn't going to correct that. But what we can correct is the drop foot. And so this is an improvement of drop foot, but it does not correct the circumduction of the hip, which in her case, she was totally happy with. This is a cerebral palsy patient. These are much tougher because they tend to have equinus and spasticity coupled with varus instability. I chose to use a Richie Dynamic Assist brace with a lateral arch suspender to evert the foot and correct the varus instability while holding the spastic calf in fixed correction. So here's how he walks. Cerebral palsy can be very challenging to treat. Look at that right side with the varus instability. But if I'm going to use a brace, I'm going to use the stability of the restricted hinge because I want to try to control his spasticity and contracture. So here he is walking with the lateral arch suspender on a fixed position Richie brace, and it's helping improve the toe drag, but because he's got proximal spasticity in his hamstrings, he's not going to have a perfectly normal gait pattern. He's got other issues more proximal, but in this case, he's very happy with the stability the Richie brace is providing for the drop foot. So there's before and after. Okay, so I'm going to open this up to any questions that might have come up. Colin?
Yep, so we have, excuse me, we have one question in so far. If you have a question, you can just click or tap the Q&A button and type it in there. Chris C asks, how does the clinician locate the ankle axis with the mechanical ankle joint axis to ensure congruency between both axes?
Yeah, that's a great question. I think that she's an orthotist who has great insight into this. And I will tell you that we rely on the anatomic axis of the ankle joint, which is determined by the location of the tip of the medial malleolus and the tip of the lateral malleolus. And there is good research showing that that truly does align with the mechanical axis of the ankle in most cases. And the location of the medial and lateral malleoli and the distal tip varies significantly in both the transverse and frontal plane from patient to patient. And we have our clinicians mark the malleoli, and then we place the location of our hinges of the Richie brace exactly at the tips of the malleoli. And it's usually offset from both the transverse and frontal plane to some degree. We definitely do not set the hinges specifically in the frontal plane because the ankle axis is angulated, and that varies from patient to patient, and again seems to be determined and located by the tips of the malleoli. So that's all done in the casting process, which is on our website and which Firefly can provide to you upon request. Real quick, I wanted to show you an interesting case of a patient who did the Camino walk across northern Spain. A lot of you in Europe and in the UK are familiar with the pilgrimage that many people make over about 450 miles across northern Spain. And I had a patient do this with a full drop foot condition wearing a Richie brace. Here's a picture of him. And here he is wearing the brace. You can see it on his left foot. And he was able to complete this walk in 35 days, which is quite admirable, meaning he averaged about 17 miles per day and hiked every day, 35 days consecutively. This is what the brace looked like and his shoe looked like when he was done. But it was quite interesting. His condition was a lower leg muscle weakness after an infection. And you can see a very mild drop foot on his left side. He drags that foot slightly, but he's otherwise quite athletic. He's got good proximal stability with his other muscles. He just lost part of his tibialis anterior after a bicycle accident. And so he was a good candidate for the dynamic assist brace. And here he is wearing that brace that he wore across northern Spain. And this allowed adequate mobility for him to complete what otherwise would be a very challenging walk for any of us to do, let alone with a mild drop foot. Charcot-Marie tooth. We've had really good success using our dynamic assist brace for this condition. As long as the patient hasn't developed contracture of the posterior calf or a fixed equinus. This is a nurse at my hospital who's had Charcot-Marie tooth since she was a child. It's a familial condition. And here she is walking barefoot without her brace, bilateral, I'm gonna turn the sound up, bilateral flaccid drop foot compensated with a steppage gait, a significant varus rotation of the feet and ankles during swing phase, and maintenance of an inverted supinated varus deformity of the hindfoot during mid-stance. She had been fitted for standard AFO braces, which she found bulky and uncomfortable, particularly in her duties as a floor nurse. And so we made her dynamic assist braces, which she loves wearing and she wears to work every day. Now she still shows some transverse plane in-toeing, but we can see good correction of the varus instability, and we're seeing her heel strike. She still compensates just by learning of a mild steppage gait, which she's done all of her life. But she has found this to be a very successful treatment, and she feels fully stable in the brace. Common peroneal nerve injury does occur in high-level athletes after a significant knee dislocation, or it can occur secondary to spinal nerve injury. And we've seen this in several elite athletes that we've treated here in the US. This is a freeze frame of a very high-level athlete at Notre Dame University playing American football. And this injury left him with a torn anterior cruciate ligament, medial collateral ligament, posterior cruciate ligament, but sadly, almost completely lacerated his common peroneal nerve. His name is Jalon Smith. He was the #1 linebacker in the United States that year, and he was supposed to be drafted #1 by our NFL draft, but his draft status dropped him to middle rounds because they thought he would never play football again. This was actually an article out of a newspaper showing his common peroneal nerve and the Richie brace, which was prescribed by his athletic trainer to treat the drop foot condition. So he wore the Richie brace during the summer months and during his rehabilitation and recovery. And lo and behold, he was able to run and perform with the dynamic assist brace on and became a starting linebacker for the Dallas Cowboys with good, excellent mobility and no evidence of drop foot as long as he had the brace on. And by his second year, he became, as we call a Pro Bowler. He made the all NFL team and signed a new contract worth $30 million. So that was a really positive thing. This is another high-level athlete for the Denver Nuggets. He had a lumbar laminectomy due to a herniated disc and left him with a mild drop foot. And he wore the Richie dynamic assist brace for an entire season and finally was able to recover and become brace free. So we have used that brace on very high-level athletes who required mobility. We're going to move on to degenerative joint disease, which is a challenging condition for many people and for many clinicians because in reality, when a patient gets DJD or osteoarthritis of either the ankle or the subtalar joint, until recently, fusion was the only option. And in some patients now today, total ankle replacement is an option, but it's not for everybody because there's strict criteria of who can get a total ankle joint replacement. The prognosis for full recovery with total ankle joint replacement is still not 100%. In every case, I would recommend considering functional bracing because in our experience, we're able to decompress and offload these arthritic joints of the ankle and hindfoot with a Richie brace with modification. Our goal of brace intervention is either to limit motion or, more importantly, decompress a joint based on the deformity and the loss of cartilage. This requires the clinician to both carefully examine the patient and identify the location of focal pain within the joint. Determine if there is frontal plane deformity, particularly in the ankle, because we can use a brace modification to address that deformity. In the ankle and the subtalar joint, we tend to use the restricted hinge Richie brace because it limits sagittal plane motion. And as I showed you earlier, it's really designed to limit the translational motion of the ankle joint that occurs after ligamentous disruption. We can add techniques to the cast correction, such as a medial skive, an arch suspender, and flanges to the foot plate to further induce valgus or varus torque and decompress proximal joints. We learned this concept when we were treating the adult acquired flat foot, because these patients get lateral compression of both the ankle and the sinus tarsi as the foot and ankle moves into extreme valgus. So as the foot, the calcaneus everts, the subtalar joint gets compression laterally, and we get sinus tarsi pain, and finally get fibula pain from the calcaneus abutting on the fibula. So our goal of bracing is to bring these bone segments away and decompress the areas of impingement. And so we learned using the medial arch suspender with the Richie brace that we could bring that foot out of extreme valgus, reposition into varus, and decompress the joint. We've learned that we only have to decompress by a few millimeters to obtain profound relief of symptoms. We don't completely straighten the joint, and we don't have to relieve symptoms. So here's a patient with impingement of the calcaneus against the fibula, and we have impingement of the lateral aspect of the dome of the talus. So we want to swing this entire foot medially using the arch suspender. And we've been able to do that with the restricted hinge Richie brace with a medial arch suspender to decompress the lateral aspect of the ankle joint. We can add additional techniques to the foot plate, as many of you are familiar with the medial skive correction on the positive cast, where we remove plaster on the medial aspect of the heel seat of the cast to induce a varus wedge shape that's transferred to the shape of the foot orthoses to wedge the foot plate and further provide inversion moment to the ankle and subtalar joint. We can wedge the foot plate externally. Sometimes if the patient isn't getting total relief, the clinician can glue or add additional felt or cork, either medially or laterally. As we push the limit, we try to decompress the joint to the point the patient has relief of pain. This can be done initially by prescribing either a medial or a lateral arch suspender, as I'm about to show you, but can be combined with wedging on the foot plate itself. We can wedge the Richie brace distally using varus or valgus sulcus wedging, which can also apply inversion or eversion moment to the proximal joints. We can apply lateral skiving if we want to decompress the medial aspect of the ankle joint, and I'm going to show you an example of that. So here's a patient with significant degenerative arthritis, DJD, of his left ankle, where his pain is primarily medial. And it's because his impingement is over the medial aspect of the talar dome and the medial malleolus. So in order to decompress this joint, we want to move the talus into valgus using a lateral skive. We want to move the talus into valgus. And we can also move the talus into valgus by applying a lateral arch suspender. So we're going to bring everything we can to bear to decompress that ankle joint. So here is a patient this is that patient whose x-ray you just saw. He's getting all of his pain medially on the ankle because of the varus deformity of the ankle and significant compression of the medial aspect of the talar dome. It's interesting, when I met this patient, he said he was able to walk the golf course if he took duct tape and taped the bottom of his shoe and brought the shoe into valgus. He didn't use those terms, but he showed me how he taped his shoe and leg with duct tape. And what he really did was show me the lateral arch suspender that we do on the Richie Brace. And so he took duct tape and taped the shoe up in this direction into extreme valgus, everting the foot and ankle to maximal end range of motion. And he said it got rid of his ankle pain, but it was very uncomfortable to wear. So knowing that, I applied the lateral arch suspender to the Richie Brace and decompressed his ankle joint. Now he still looks like he has a varus deformity because it's a fixed deformity in his ankle, but he has no pain. I've decompressed his ankle just to the point, a few millimeters, where he doesn't have pain. So we go by subjective feedback. If he didn't have relief of pain, I would continue to wedge the foot plate of the Richie Brace more into valgus, but I didn't need to because he had profound pain relief right away. If you don't believe it, this is a letter and a card he sent me. That's that same patient, a young athletic guy debilitated with DJD of the ankle, but with that brace on, he was able to climb what is known as Camelback Mountain in Phoenix, Arizona, when his son graduated from university. So it was a remarkable turnaround of his disability, enabling him to have enjoy something like this, a truly life-changing experience. So I'm going to open it up to any questions on DJD before we go on to other pathologies.
I'll just remind people they can get their questions in using the Q&A button, and you can just type them in there. And this is a great opportunity to ask Dr. Doug Richie some questions. So we have one question, another question from Chris C again. And this might have been related to the first piece. Doug, Chris asks, what do you think about the double and triple ankle joints from Becker to achieve similar outcomes?
Oh, those are absolutely fantastic. And Becker happily has become a Richie Brace partner and a distributor. And I've spent time in their facility with their orthotists. And we are exploring how we can use that triple action ankle joint on a Richie Brace or a Richie type brace. And I'm hoping that's something we can do in the future, hopefully within the next year. Boy, that really requires some great knowledge of biomechanics and engineering, and it will take a lot of training of our podiatrists to understand it. But I think once we do that, it's just a marvelous breakthrough. So I'm glad you brought that up. And if any of you are interested in just learning about it, you can go to the Becker website. Becker Orthopedics is located in Michigan, and they're a USA company, but they distribute all over the world. So looking forward to that in the future. That's a great segue into moving beyond.
Just one question, Doug, from Penny Bailey. Those previous questions have come in from Chris Cox, who's in the UK. This is Penny Bailey, and Penny asks, have you ever had to use a steroid injection for those with DJD in the lateral ankle in combination with the brace?
You know, I've injected many ankles with DJD for temporary relief if they were going away on vacation, having a wedding, you know, a big event, but always knowing, and the patient knowing, it's short-lived. I prefer not injecting with the brace because I want to get the patient's feedback and know that everything that I'm getting from the brace is real. It's not being clouded by the steroid injection. So I want real feedback without the influence of a steroid injection. I want to make the brace as effective as I can in relieving pain. If I can't relieve the pain with the brace, yes, I'll use the injection as a short-term temporary relief. But long-term goal is to make the brace obviate the need for any injection.
Okay.
I'm just going to finish with tendinopathy because MSK podiatrists treat a lot of tendinopathy. And while the buzzword today is doing gradual loading and load management and rehab and gradual strengthening, I still know, having treated thousands of patients with tendinopathy, that during the initial stage of the rehabilitation process, particularly if there's a documented tear of the tendon, that you have to offload and protect the tendon while allowing full range of motion and allowing the rehabilitation process to take place with load management and hopefully eventually getting rid of the brace. And we've learned that the Richie brace is a wonderful adjunct to rehabilitation of these various tendinopathy conditions. We've already talked about posterior tib tendinopathy, but I want to talk to you about tibialis anterior and peroneal tendinopathy, which are getting more and more common around the world for reasons to be discussed later. Tibialis anterior, often misdiagnosed. Patients present with midfoot pain. Usually the tendinopathy is felt at the insertional area on the medial cuneiform. And many doctors misdiagnose it as a joint problem, an arthritic problem, a hypermobile first ray, etc., when in fact it's really the distal insertional area of the tibialis anterior that has become degenerated and sometimes even partially torn. My book, which I'm plugging here, is available from Springer, gave me an opportunity to really study muscle moment arms and muscle action. And I became aware of the fact that, at least the way I was trained, overlooked the true knowledge of muscle function that I think is essentially necessary to treat tendinopathy. And I'm going to share that with you just briefly. For example, the tibialis anterior, we have to appreciate that it has two contractions during the walking gait cycle. It contracts throughout all of swing phase, but it also contracts during what is called the loading response right after initial contact. Podiatrists call this contact phase of gait, but it doesn't contract at all during mid-stance. And so the strain on the tibialis anterior really occurs during the eccentric loading during the contact phase, right after heel strike. And it's there that the maximal load is placed on the tibialis anterior, and it's there that the damage occurs. And so right at the moment of heel strike, the tibialis anterior fires to guide the foot to the ground, to decelerate the rapid plantar flexion of the ankle during the loading response. We found, and I found that during my clinical practice, that as fitness walking became more and more popular, particularly for middle-aged women, we began seeing a rampant number of tibialis anterior tendinopathy because fitness walking, power walking, accentuates the stride length and accentuates the dorsiflexion and resultant plantar flexion of the ankle during the contact phase of gait. Indeed, this study published quite a while ago in 2009, one of the few studies on tibialis anterior tendinopathy in a large orthopedic group in the United States. Out of 29 patients that presented with and were diagnosed with tibialis anterior tendinopathy over a 5-year period, 27 of 29 were women. And why is that? Is it just because women enjoy fitness walking? Or is it this? The marked plantar flexion of the ankle brought about by elevated fashionable footwear creates greater eccentric loading of the tibialis anterior during just even casual walking. So there's a number of factors that come into play that the treating practitioner needs to identify and modify. That article proposed a very simple clinical test to load the tibialis anterior and help diagnose that indeed it's this tendon that's injured in this patient. And by passively plantar flexing and everting the foot maximally to end range, it will elicit pain right at the insertion of the tibialis anterior at the medial cuneiform. I find that I call this the heel rocker test. I simply have the patient lean against the wall and lift the toes off the ground, maximally dorsiflexing the ankles. This will bring out the pain immediately at the distal insertion of the tibialis anterior if there is tendinopathy. So the increased equinus positioning puts increased eccentric load on the tibialis anterior. Our solution for offloading is the Dorsey Assist AFO or a fixed position AFO. In both cases, they will offload the tibialis anterior. And in many cases, we have them wear a brace to bed at night because when they lie in bed at night with the ankle in plantar flexion, it loads the damaged tendon. So this dynamic assist is really an ideal offloader of the tibialis anterior because it maintains ankle dorsiflexion during swing, it controls ankle plantar flexion during the contact phase, and it still allows free ankle dorsiflexion during mid-stance. Now we could achieve the first two by using the restricted hinge Richie brace, but we will not get free ankle joint dorsiflexion in that brace. Finally, perineal tendinopathy. We seem to be seeing more and more of this. Pain, swelling, disability located along either the peroneus longus or the peroneus brevis. We know that patients with pain in this area can have simple tenosynovitis. They may have progressed to degeneration and tendinosis. Keep in mind, some of these patients undergo subluxation and dislocation. They can have an os perineum disorder, and they can actually have an acute tear. So we have to work them up carefully to come up with the correct diagnosis. But in almost every case, we're going to initially treat with offloading. It's interesting to look at the studies that have been done on muscle moment capacity of the perineals. And what's interesting is the perineals actually provide more frontal plane stability to the ankle than the tibialis posterior. The peroneus longus develops 13.4 Newton meters of eversion strength at the ankle compared to the tibialis posterior, providing only half that amount of power in the direction of inversion. So the peroneus longus is really the primary everter of the ankle, not the peroneus brevis. The purpose of the peroneus longus is to evert or pronate the forefoot during the heel rise or terminal stance phase of gait so that we push off across the transverse axis across the great toe joint, so that we don't push off like the chimpanzee or other primates on the oblique axis. So it's the peroneus longus that's critical to engage the transverse axis and a stable push off across the hallux. And so if we look at the work of Jacqueline Perry, we see that the peroneus longus and the brevis fire in terminal stance only. They don't fire at mid stance and they don't fire during the contact phase. That's important to keep in mind. I'm going to keep going here. I'm going to show you why that's important in a moment. Patients present with pain and swelling, usually just distal to the tip of the lateral malleolus. We will often see this accompanied by some varus deformity of the rear foot. And in fact, studies have shown that patients who get perineal pathology tend to have varus of the hindfoot, or they have chronic ankle instability from a previous grade 2 or grade 3 ankle sprain. So we can use a Richie brace to try to simultaneously balance the forefoot to the rear foot, evert the calcaneus, and then control inversion of the entire ankle joint complex, particularly when the heel comes off the ground. At this point, the foot orthotic is ineffective, but a Richie brace with continued contact all the way to the leg can continue to control the foot and ankle during terminal stance. A little pearl to reproduce perineal tendon pain is have the patient do a lunge. An extreme lunge pulls those tendons into the lateral malleolus and will reproduce the pain and help confirm the diagnosis. Terminal stance is when the peroneals fire. The heel is already off the ground. So if we want to do posting or wedging, we tend to do it up in the sulcus or forefoot. It's really not that effective in the rear foot because we're really trying to affect and offload the peroneals when they fire in terminal stance when the heel is already off the ground. We've also learned from muscle studies that the peroneals are pretty important dorsiflexors of the foot and ankle. And so maintaining the foot into dorsiflexion seems to also help with offloading. So that's why I prefer using the fixed position restricted hinge Richie brace for peroneal pathology. So this is the brace I prefer to offload the peroneals. It holds the ankle at 90. It allows some dorsiflexion during the stance phase, but we can add these eversion enhancements to the brace to offload the peroneals. One way to evert the foot is to add a medial flange to the arch of the foot plate. We talked about this in the previous webinar. When we slope the foot plate into a medial flange, we tend to abduct the foot or evert it. We tend to drive the foot laterally. So a medial flange will abduct the foot and pronate it and offload the peroneals. A medial flange, well, I'm going to jump ahead here. A lateral flange helps prevent the foot from abducting. A medial flange acts as a wall to prevent adduction. We talked about this significantly in the last webinar, which you can review. So when I have a patient with a cavus foot, I prefer a foot orthotic or a Richie brace that has a medial flange because it tends to pronate the foot. Medial flange, lateral heel skive. And for the peroneals, we put a sulcus wedge, a valgus extended forefoot post, because that's going to come into play during heel rise or during the terminal stance phase of gait. So we can even add the lateral arch suspender to further evert the foot with peroneal tendon pathology. I showed you this earlier. We can add additional forefoot posting to the Richie brace, or what I think is more effective is let's extend this post distally to the sulcus of the foot, where we now get eversion moment during heel rise, which is when we most want to offload the peroneals. Okay, so one final little pearl, always evaluate for tibial verum, because if there is significant tibial verum, it's going to invert the foot plate of the brace if we brace the foot plate and align the foot plate to the limb uprights like we do for every standard prescription. If they have an inverted tibia, it's going to invert the foot plate. And we need to know this ahead of time. This is a case where the inverted tibial verum is inverting the entire foot plate and the patient's foot. What we recommend is if there's more than 6 degrees of tibial verum, you tell us how much verum there is in the tibia and how much you want us to correct the alignment of the limb uprights so that we won't invert the foot plate to the ground and cause increased strain of the peroneals, when what we really want to do is create decreased strain on the peroneals. So looking for tibial verum when we're offloading a cavus foot or extreme lateral instability is really important for us so we can gain maximal control over the foot plate. Okay, so hopefully that's a lot of stuff, but don't forget, when you do this, some of these outcomes are among the most gratifying experiences you can have in clinical practice. And I think our friends at Firefly Orthoses are very well schooled in all of the factors that I brought out today, and with the prescription writing and the casting technique, that they can really successfully guide you through this when you're ready to embark on using the Richie brace to treat conditions other than adult acquired flat foot. So thank you very much. With that, I'm going to turn it over to Colin for any other questions.
We have nothing at the moment in the Q&A. Martin, do you have any thoughts or observations on Dr. Richie's presentation?
Yeah, I mean, fantastic. Thanks very much, Doug. Lots of little pearls of wisdom there to share with us. Um, I think it's kind of what I would say it's kind of a learning curve when you start to introduce Richie Brace therapy to your clinical practice. And on a weekly basis, I am receiving WhatsApp messages and videos and case presentations and working with our team to try and help people decide, what is the correct Richie Brace, what is the prescription, and just giving the feedback to the clinicians who are just starting to embark on Richie Brace therapy. So yeah, I mean, I think if anyone does want to reach out, you can email me directly on martin@firefly.ie. So that's martin@firefly.ie. We can exchange emails, and then we can potentially exchange numbers and get onto some sort of social media channel that you like, where we can share videos and so on. I think that works really well. No, apart from that, I think that's a great presentation, lots of information in it, and it'll generate questions maybe over the next few days in people's clinics. So just reach out to Firefly for any assistance if you require it.
Chris Cox is back again. He asks, can I ask an off-topic question? He says, I've had the pleasure of spending time with Kevin Kirby and Rich Blake, and I'd like to know what your decision-making would be when making the decision between foot orthosis and Richie Brace. Do you have an assessment test to help better inform your decisions?
Well, yeah, that's a great question. All of the conditions that I showed here, well, I guess not all, but most of what I showed you here, a foot orthosis is not indicated and cannot control drop foot. It cannot offload the tibialis anterior. They can, to some degree, offload the peroneals. But I think that question about foot orthotic versus Richie Brace really comes into play with adult acquired flat foot. And we talked about that in my webinar. And in my opinion, in my experience, if you have evidence of spring ligament rupture, a foot orthosis cannot control the transverse plane motion of the talonavicular joint that has now lost stability due to rupture of the spring ligament. And so I showed in that webinar 2 tests for spring ligament insufficiency. One is the lateral forefoot push test, and the other is the simple single foot heel rise. If the patient fails either of those tests, in my experience, they're going to fail with a foot orthosis. One could argue, why not try the foot orthosis first? And I have no problem with that, but sometimes there's economic factors that come into play. And finally, the majority of patients that I put in Richie braces in my practice already were wearing foot orthoses. The decision was already made. They would come in wearing a foot orthotic because they were diagnosed and treated with flat foot at a much earlier age, and now it's not controlling them anymore, and they're symptomatic. So I don't think that's as hard of a decision as it might sound. And I know that there's clinicians that are just very trusting of their own ability with foot orthoses, like Rich Blake and like Kevin Kirby, where they push the envelope with foot orthoses. And in Kevin's case, he combines it with a high top hiking boot to try to get some of the effects that I showed you in my slides. So, and that's his choice. I mean, I prefer not putting patients in hiking boots, but whatever it takes and what works in your hands obviously tends to direct a lot of your treatment decisions.
I think we have one question here from George Hill. Would you ever consider FAO for complete lateral ATF, calcaneo fib, etc.?
Oh, sure. And that might be something that we could talk about maybe in another webinar, but the management of the ankle sprain, both the acute and long-term management is right down the Richie Brace alley, because one thing we're learning, and I'm giving a lecture on this at the Western Podiatry Congress in 2 days out here. It's our biggest meeting in the Western United States. And I'm going to devote my lecture to the fact that we're now understanding that the ankle ligaments take up to 6 months to heal. And sending these athletes back to play 10 days after a ruptured ATFL or calcaneal fib is dooming them to ultimate osteoarthritis in their ankle 10, 20 years later. And as much as athletes always were resistant to bracing, unless we brace these ankles after acute ligamentous disruption, they will not heal. And especially if you send them back to play. And so we can offload and stabilize the calcaneofibular ligament and the anterior talofibular ligament with a articulated Richie brace. We don't have to put them in a cast. We don't have to put them in a walking boot. We can allow sagittal plane motion of the ankle joint. The anterior talofibular ligament is a restraint of internal rotation of the foot at the ankle joint. It's a stabilizer in the transverse plane. The calcaneofibular ligament is a stabilizer in the frontal plane. And we can stabilize using the Richie brace in both those planes and still allow sagittal plane motion. So yes, that's a whole great indication for bracing for the ruptured ligament complex of the ankle.
Yes, Doug, just to jump in there, we have a group of orthopedic surgeons that now refer to us for Richie brace rehabilitation, and it's for acute inversion ankle injuries. And therefore, the Richie brace is used for a temporary period of rehab. And I think for us as podiatrists, sometimes we think that you use Richie braces infinitum, forever. And one of the great things that I've learned is that sometimes you use them for a short or maybe up to 12-month period of time and then move on to functional foot orthoses or other sort of rehabilitation exercise programs. So yeah, excellent.
Yeah, absolutely right. It's good to hear, Martin.
Yeah, I think part of that is the role as the podiatrist to educate the referral sources, because really most of them will not have heard of the Richie Brace AFO. So, good quality letter writing back to the referral sources starts to inform them about what we can do with the Richie Brace. And of course, the key thing is that the foot plate is an intrinsically balanced, custom-made foot orthosis. And again, they're not familiar with that because most of the solid AFOs they're seeing just simply don't have that, or they have a small little arch support, but they have no intrinsic cast corrections to control and alter that frontal plane and transverse plane. Yeah.
Right.
Okay, great. Anything else there, Connor, that we need to address, or shall we wrap it up?
I think we have covered all. Just to reiterate what Martin has said, if you are interested in finding out more about the Richie brace, or if you would like us to send you out a Richie brace catalog and a Firefly starter pack, you can email myself with your details, or you can contact info@firefly.ie, and we'll be happy to get all relevant information out of you. And just finally, the webinar will be available to you all. I'll distribute it through email. And just to say thank you very much to Dr. Doug Richie for this evening and the earlier webinar that you delivered. We appreciate your time.
Yeah, and real quick, if anybody has any questions for me, this is my email here. It's basically my name, D. Richie Jr. at good old fashioned AOL.